Thank you so much, Dr. Azam, for having me in this meeting. It's lovely to see all my friends, Ramesh, Sanjay, and all the rest of you. The airport saga wasn't much at all. It's very well worth coming to this meeting when I see this amazing audience here. So why do we need IVUS? I think it's an important question for this year. And some of the trials, some of the recommendations that are there. So let me take you back a few years. This is a case from our own cath lab. One of my colleagues, a 67-year-old gentleman, and you can see the circ and the ramus lesions. He underwent an angioplasty and they put in cipher stents at that time. So this is from a few years ago. And got an angiographically good result. On day 3, he had severe chest pain, and they switched from clopidogrel to ticagrelor, and this was the stent thrombosed right there. The operator went in quickly and opened the arteries with balloon dilatation, established immediate flow, and he thought that this was prasugrel resistance. However, clopidogrel resistance. On day 6, had another chest pain and he thrombosed this circumflex again. I was on call on that evening, so we took him up, established flow, and then put in an IVUS catheter to see what we had. We saw distal dissection. We saw that distally there was a plaque burden of more than 70%. It was a very underdeployed stent, undersized for the artery. Artery was approximately 3.5, and the stent had not measured to 2.5 as well. And you can see a lot of thrombus with filling defects all around. And the proximal edge of the stent was put in an area which is more than 70%, and that too high-risk plaque. So when you look at these 4 things, which is under expansion, malapposition, edge dissection distally, and a plaque burden of more than 70%, this is exactly all those things which we know from the previous trial, like the Horizons trial, and the association with when you take all the stent thrombosis that happen, you can see that one of these things happen in at least 50% of our patients. And most of the patients will have one or more of these IVUS findings. When we look at acute stent thrombosis, we do a procedure, we think this is a garden variety angioplasty. Most of us in the audience would probably put a stent in an LED like this with the eyes shut and a hands tied behind the back. And we always question, why do I need IVUS in this? And this is exactly what the operator thought. And he put in a stent, and this is the result. Looks like it's a great result, but when you're 30 minutes down, he's seeing a filling defect. And post angioplasty, when he pulled it out, he saw a huge filling defect over there, chased it for 30 minutes. Now, at this point, we put in an IVUS catheter, and what did we find? We found as you go from below up, you can see dissections, you can see grossly undersized and underexpanded stents. And not only that, when you come to the proximal edge, you can see stent deformation. He has actually pushed all the stent onto one side of the artery, and he has left dissected planes on both sides of the stent. In my opinion, all this could have been avoided by just doing an intravascular imaging through the procedure, and you can almost deal with all of them, thereby almost taking away this complication of subacute stent thrombosis. Moving away from stent thrombosis and acute ischemic insults, this 61-year-old gentleman, 10 years post-renal transplant, unstable angina with a calcified RCA, and you can see the varied steps. The operator did a rotational atherectomy and then prepared the lesion well, and then put in stents all the way to the ostium of the right coronary artery. Now, this was his final result, and at 1 year, he had symptoms that was through the thick of the COVID, so he went through the symptoms, came to us at 3 years, and you can see that his right coronary artery has got an ISR at the proximal end. So we got him into the cath lab, and it was tough, so we had started using ELCA for this indication, so we used a laser to get into the artery. The lower energies didn't work, so the higher energies worked, established flow. And then once we got flow, we got an IVUS catheter down. So what did the IVUS show? This is what the IVUS shows. When you look at the IVUS and you look at the images, You can see the cross section of the stents as you go along the path, and right over there. When you go from A, B, C, and D, these are the images corresponding. A looks like a well-expanded stent over there. But as you come towards the ostium, you can see that the stent is not even reached the ostium. So the guide catheter has deformed the stent, and this is inadvertently done for all these osteal lesions without even knowing it in the index procedure. And not only that, you can see that the MSA here is only 2.9, which means that you not only have pushed it forward, but you've deformed it to a point where there is a very unexpanded stent which has gone and was failed to recognize at that time. So a previous stent inadvertently deformed, which is probably the reason for this ISR. So this is how IVUS helps in these patients. I mean, this is a repeat of that slide. And I'm going to go to the next. So how do we do it? When we have IVUS in a standard procedure, like all these cases that I showed, what we really need to do is we need to image as and when we can. And it is important to image not just after the stent, like some of the trials I mentioned and done, but what is important is the pre-stent imaging. It used to be pre-PCI imaging before you even start doing the angioplasty, but when 35% of our cases are calcified, it is impossible to get an IVUS catheter in there prior to doing a rotational atherectomy or preparation of some sort. So at least an imaging should be performed prior to putting a stent in. And what does it show? It shows that you determine a distal landing zone, which has a plaque burden of less than 50%, and some trials would say 40%. You establish a proximal landing zone, which is again a similar low plaque burden of 40% or less or 50% or less plaque burden. And these have to be stable plaques. So you know automatically the distance and the length of your stent in between that you will require. The question is, do you take reference vessel diameters, that means EL to EL, to size your stent, or do you take lumen, which is from the luminal end to a luminal end in 2 sections? I think if you look at various trials have used various methodologies. But what I do in my practice is very simple. Take lumen to lumen. And in this case, the lumen here said 2.7, it's 3.8. So I know that I need to take a 3.0 stent at the distal end and probably expand it to 4.0 proximally, and then the length. And once you've done that, what is important is the images in the center, which are the core images. And these core images, whether they are soft, whether they're eccentric, whether they are calcified, whether they have thrombus, will determine the device that you pull out from your shelf to prepare the lesion before you get this ready for your stent implantation. Once you've implanted your stent, what's important is to look at both the edges, the proximal and the distal edge, and make sure that you have an MSA which is requisite to what your destination MSA was. What I mean with that is, when you divide your entire artery, you know that you have if you had a 4.0 artery expected in the proximal segment, then the destination MSA for that is 12.5. And if you have achieved 90% of that, then you're optimal. But if you're between 80 and 90, you're suboptimal, but you're still acceptable. So I think we need to do this in every case as a rule. The question is, why do we need IVUS again? In that it is to enable us to do a job better than we did and help us understand from our mistakes and set a correction course. The other question is, do we have enough data to support this? And the data comes from, I'm going to ignore the trials which came in earlier, but because there was a mix of many other stents, the older generation and the newer generation stents in that. But from 2015, when you look at these 2 papers, one was the IVUS XPL, and the other is the IVUS CTO data. What did they show? These trials showed that when you use IVUS systematically, it reduces MACE rates. Subsequently, we had the ultimate trial in 2018, which has published its 3-year follow-up in 2021, and now we have the Renovate PCI. So let's look at these 2 trials a little more closely. So when you look at the ultimate trial, which came out of China, which is a very well-performed trial, the goals they set The goals they set was a minimal cross-sectional area for a stent to be more than 5 millimeters square, or to be at least 90% of the MLA at the distal landing zone. That means, in short, that when you have a regulation stent of 15 millimeters so, and if you have a distal reference vessel, which is 3 millimeters in lumen, then you will match a 3 millimeter diameter through the entire length of the stent. And if this stent becomes longer, then you account for that length and try to progressively increase the size of the stent in the proximal segment. The edge, they also wanted the edge of the edge plaque burden to be less than 50% at both ends. I think this is important. And no edge dissections. 53% met the criteria. And when they looked at the 1-year data, they showed that the target vessel failure rate was significantly better in the IVUS-guided angioplasties. This was their conclusion. The 3-year outcomes, which was published last year, showed that part of them, around 96% of them, went through a follow-up. And at 3 years, what they showed was that not just it significantly lowered TF and maintained that for 3 years, but it reduced stent thrombosis as well in this group of patients. The people who had optimization achieved by IVUS, which was around 53% of patients, did better than those people where optimization was not achieved. So it's important not just, it brings us to a very important question, and this is the Renovate trial, which again, said the same thing. It concluded saying that the intravascular image-guided PCI led to a low risk of composite death from cardiac causes, target vessel-related myocardial infarction, and clinically driven TLR over and above the angiographic-treated patients. Why is the acceptance still low? When I look at the guidelines, say, 2021 ACC guidelines put it at a 2A with level of evidence B for left main PCI and complex PCI, but when it comes to stent failure, it's level of evidence C. Imaging is performed in 15% of PCI procedures, and this is from a survey. But the problem with this question is, I kind of put it this way, are 15% of those procedures image-guided truly, or are operators just putting in imaging catheters and not looking at those images at all and still following the angiographic norms? I think that is more important. I think the reason why the penetration is low is because of the unfamiliarity of the equipment, knowledge and gaps, perception that it takes more time, and the workflow efficiency, and of course, the reimbursements. Where do we go? We need to have training programs, and this has been highlighted at operator level. We need to educate, have more CMEs, workshops on this, institution level and other levels, to make sure that standardized protocols for imaging percolate into the system and are followed by most operators. Thank you.